Morning. And we'll give it a minute and then we'll get going. I guess we're good. Let's just go right ahead. Good morning. Hope everybody had a nice weekend. And let's go forward. Okay, so this is a V-stim study. This is a tetralogy flow patient who had an arrest and underwent a V-stim study. So the question is, what was induced here and how would you manage this? So why don't we ask Maya, what do you think we got going on here?
All right, morning, Dr. Pass. Okay, so looks initially like probably a sinus rhythm, not perfectly clear.
And
And
just
then,
let me be clear because it's this is like a really strange looking tracing, right? But this is two extra stimuli, S2 and S3, in the ventricle,
okay,
just so you know.
okay.
Because I know it doesn't really look like usual tracings that we see, but
Mm-hmm.
it's also no lines on it.
Right.
Trying to make it as completely crazy as possible.
Okay. Um, so then it does look like it's going into probably V-fib.
Mm-hmm.
And in lead V1, it kind of looks like torsades a little bit. Like it looks like it's that like spindle formation a bit. But it looks like, yeah, we go into V-fib here.
So I agree with you. I agree with every single thing you've said. Let me ask you though, what is the formal definition of torsade? I agree, it kind of looks like that, right? Because torsade means like torsade's a point is like spinning around the point and sort of like a polymorphic VT.
Mm-hmm.
But is there something special about what's the difference between just regular polymorphic VT and torsade polymorphic VT?
I think it's like the waxing and waning kind of like it has to be that similar pattern that's repeating.
That's a good guess. It's possibly true, but actually, the main difference is, and this is a term, people misuse the term torsade quite frequently. Torsade is polymorphic VT in the setting of a long QT interval,
Right. Okay.
whereas other polymorphic VT we would just call polymorphic VT. I mean, you could say it looks like torsade. That's perfectly perfectly reasonable. But I think that we would, but really we don't know if this is torsade because we don't actually know what the QT interval is. Um, but presumably if the patient has tetralogy, it'd be very bad luck to have long QT syndrome and tetralogy. It's conceivable, I guess, but not sure I've seen it. So if you had someone who arrested and then had this, so this is with two ventricular extra stimuli, there's an S2 and an S3. Um, would you consider this to be a positive study or a negative study, do you think?
This would be a positive
Yeah,
study.
yeah, this would be positive. So let's just briefly, I'll just talk you through what we do in a VSTIM study because you don't see it done very often, right? We don't do a lot of VSTIM studies, so it's possible that quite a few of you have not yet seen one of them. So in a VSTIM study, what we're doing is we put single and then double and then triple ventricular extra stimuli into sinus rhythm. And really, the goal of the study is to see if we can induce VT or VF. And the bottom line is that if I tried hard enough, I could put anybody into VF. All of us could go into VF if enough stimulation was put into the ventricle during a pacing study. Um, and so if so the typical technique is that you first put single extra stimuli in until you reach the refractoriness of the ventricle. And then what you do is you put in double extra stimuli, and typically electrophysiologists will start either 30 or 50 milliseconds longer than the refractory period. And the goal is to essentially hit as many permutations as possible in double extra stimuli. And if you don't induce anything with double extra stimuli, then you stop basically when the S2 doesn't capture anymore, because that suggests you're so early with your extra stim that it's no sense going further because you can't capture the ventricle. And then you go to triple extra stimuli. One of the problems with V-stim studies is that, as I said earlier, anybody can be induced into VF or VT if you try hard enough. And so sometimes tests can be very nebulous, what the results mean. So, for example, if I took anybody in the group, if I put UMI on the table and I put in triple extra stimuli at like 200, 200, 200, meaning very, very rapid triple ventricular extra stimuli, and I induced VT, I don't know what that means in a healthy person like yourself. It probably means nothing. It just probably means you're in the group of people who, if you try hard enough, you can make them go into VF. And so when we're doing a V-stim study, we're always happy when we're not able to induce with double extra stimuli. And with triple extra stimuli, it always gets us nervous when we have to start getting more and more premature with our extra stimuli, because as we become more and more premature, the specificity of the study goes down because of the fact that a small percentage of people will be positive, even though they are not at risk for spontaneous ventricular arrhythmias. So in this particular case on this tracing, this patient is only in double extra stimuli. And I think it would be fair to say that most electrophysiologists would say that if you induce this type of arrhythmia with just double extra stimuli at almost any interval, that would be very positive. In other words, the vast majority of healthy individuals who do not have predisposition to VT will not have this arrhythmia response to double extra stimuli. When we get to triple extra stimuli, it gets much more nebulous, and sometimes it's hard to know what to do when somebody is positive, but only positive when they're like at 400, 200, 200, 200. That when you're stimulating the heart that aggressively, the specificity falls, and sometimes we're left in a difficult situation. Now, in this particular case, one could argue that if a tetralogy patient arrested, a V-stim study might not even be necessary. Sometimes we'll do one on the theory that maybe there is a spontaneous, stable, monomorphic VT that could be amenable to ablation. But as a general rule, because we don't trust ablation in tetralogy as being definitively protective, almost anybody with tetralogy, with a few exceptions, would deserve a defibrillator if they had arrested and had the diagnosis of tetralogy. The fact that this study is so positive certainly would argue for defibrillator. This arrhythmia is not slow enough that it could be mapped and ablated easily in the rhythm. Now, there are some who would consider putting a patient on ECMO, inducing a life-threatening arrhythmia, not this type, but if, for example, a monomorphic VT was obtained that was very fast, but was consistent, but was hemodynamically embarrassing, some might consider putting the patient on ECMO and then mapping that arrhythmia in tachycardia while on ECMO to provide adequate perfusion. I've never done that, but it has been reported rarely, and I think in the adult world it's done with some regularity because VT is so common after myocardial infarction. But in this particular case that we're looking at, I think if somebody arrested, we would, and then had this finding, I think, basically you would almost certainly be set up in that same procedure to place a defibrillator or at least have it ready for the next day. You would not send somebody home with this finding who has tetralogy, who had this response. Okay. Any questions about any of that? All right, move forward. All righty. So this is somebody who is in tachycardia, and a PVC has been placed. And I will mention that it is occurring at the time of the bundle of His deflection. So here's A, H, V, A, H, V, A, and then the H, but then they put a PVC in at exactly the same time. And you can see it's a PVC because the QRS morphology completely changes. So the question here is, what is the mechanism of tachycardia? Anybody want to offer any thoughts on this? All right. So let me go through this. So remember that, so let me ask Christina. Christina, if somebody has SVT and they're not pre-excited, what are the two most likely diagnoses in pediatrics to explain SVT? In other words, you're on call, it's your first night as an attending. The fellow calls you at home and says, we have a patient in the emergency room who just broke out of SVT. What are you thinking in your mind is the two most likely diagnoses? What would constitute like 97% of the correct diagnosis?
Good morning, Dr. Pass.
Hello.
So if it's a new patient and I don't know their history and they might have a SVT, so I think is it a AVRT, AV reentrant tachycardia, or AVNRT?
Right,
AV
right.
no reentrant tachycardia.
That's right. Those are the two most likely. So orthodromic reentry or AVNRT. So first thing is they're very nice here on this tracing, they being me, and they have listed the interval between the tachycardia beats. So the first thing I'm going to ask is, does anybody have any thoughts on this? Tachycardia has a cycle length of 460. So any thoughts based on that fact as to what the likely mechanism of tachycardia could be? Is that a fast or a slow tachycardia for an SVT?
I would think that is
Pretty slow.
Pretty slow, right? It's like a heart rate of about 130 or 135 beats per minute. So does that point you sort of just using what we know about AVNRT versus orthodromic reentry? Does that give you any directionality in terms of your thought process? And again, these are all just clues. None of them are definitive, but you know, it's like when you're doing an EP study, we're often gathering our evidence to make a diagnosis.
it's
I think
probably
Go ahead. I think Dr. Capeman, you were speaking.
sorry. I think given that the rate's on the slower end, it's less likely to be an AVNRT type.
Okay, actually, AVNRT in general is the slower one on average, not a guarantee at all, but in general, when the people have AVNRT, the rhythm is usually a little slower. So in kids, I'd say most of the time, at least when we're under anesthesia, a typical AVNRT might be 180 as opposed to ORT, which might be 200. And again, I want to be clear, this is just a generalization. It is not true of everyone. We know that people have pathways that conduct fast or slow, or some people's AVNRT can be very fast. So you can't hang your hat on it. But if somebody just said to me, if I were on call and you said, well, somebody was just an SVT and it broke with adenosine and the heart rate was 130, I would be thinking, I wonder if that's AVNRT. But I'll be honest in saying that's a very slow rate, even for AVNRT. But again, this is an EP study we're looking at and patients under anesthesia. So it may be that the rate is not a fair test. So, okay, so that's the first thing. So now we have a PVC during, so PVCs during his refractoriness, we've reviewed a long time ago now, can help us determine or distinguish between AVNRT and ORT, and I'll show you. So this is an example of ORT. So in ORT, we're going from the atrium to the ventricle, and we're going through the AV node and his Purkinje system down to the ventricle, and then, of course, back up the accessory pathway to the atrium, and so on and so forth. This is the pattern of SVT. okay, or ORT. Now, if I place a PVC into tachycardia at precisely the moment that the bundle of His has just fired, or moments afterwards, milliseconds afterwards, then the His will be refractory. And so that PVC can only go from the ventricle to the atrium through an accessory pathway because the His is refractory. So if I pace the ventricle at exactly the moment that the His has fired, or moments afterwards, then I will basically depolarize the ventricle faster than it would normally during ORT, because it would normally take, let's say 30 or 40 milliseconds for the impulse to go from the bundle of His down to the ventricle. So by pre-exciting the ventricle, by pacing at the moment of the bundle of His, if there is an accessory pathway, the next atrial depolarization will be early because there is an accessory pathway that allows this early PVC, this premature ventricular contraction, to go up through the pathway and reset the tachycardia so that the next A is early. Does that make sense? Now let's look at the contradistinction, which is AVNRT. Now, if you're in AVNRT, we know that the reentry is within the AV node itself with a slow and a fast pathway. And so during tachycardia, the atrium and the ventricle are essentially being passively depolarized as the reentry occurs within the AV node. So if you have reentry within the AV node, then basically what's happening is that when the impulse goes through the around the reentrant circuit up the fast pathway, what happens is the atrium is depolarized, and then it goes down the slow pathway, and then the His and the ventricle is depolarized. Now, if I put a PVC in at exactly the moment that the His fires, when the His is refractory, that means that this PVC will not be able to conduct from the V to the A, because the only way in someone who does not have an accessory pathway to go from V to A is to go back up through the His-Purkinje system through the AV node retrograde. And so if there is no accessory pathway and I put a PVC in at exactly the moment that the His has fired, essentially the bridge is closed for a moment, the next A will be perfectly on time because this PVC will be unable to interrupt the reentry, because the His bundle will essentially block any VA conduction temporarily because it is refractory. So when you put a PVC into tachycardia of AVNRT at a moment that the His is refractory, the following A should be perfectly on time if the patient is having AVNRT, as opposed to ORT, where we've just described that the PVC will cause the next A to be early, because even though the His is refractory, you have this additional mechanism for the impulse to go from the V to the A. Does that make sense?
So Dr. Pass, in the previous slide, it looked like you were at cycle length 460, 460, and then it dropped to 425.
Right. So let's go back to that. Yes. Okay. Yes. So
So
what does
then-
that mean?
So it means that there was a pathway for that next atrial impulse to come earlier.
Right. So that means this
ORT.
was ORT. That's right.
And then with that rate, would you assume, like, would you be able, I'm trying to think ORT in this patient with a rate of 130, would that be more like a PJRT type picture?
That's exactly right. That's a very, very astute comment, Dr. Capon, which we're happy to hear since you have 10 minutes left as a fellow. But that's great. That's exactly right, right? So, but this is a nice example. First of all, it's nice because it shows us an example of a His refractory PVC being placed and advancement of the next day. But it also shows us how you can't hang your hat on any single rule when you're doing an ablation or an EP study in terms of mechanism, right? This patient, on the one hand, I spent a fair amount of time telling you that the rate of the tachycardia can be very useful in trying to determine what the mechanism is. And we were saying that AVNRT in general should be slower. So by that criterion, we would think that this is probably some form of AVNRT. But when we put a PVC in during His refractoriness, we actually can advance the next A. And so, and the other thing that kind of clearly shows, or I should say, is suggestive of the fact that this is not AVNRT, is that the author or the person who made this diagram shows us that this RA signal is in the lateral right atrium. So normally in AVNRT, where would the earliest retrograde A be? Yes,
Close to the his.
yes, it would be in the His, right? Because in AVNRT, right, you're going up, you know, all the reentry is here. So the His A should be the earliest, and so, whoops. And so in this example, what we see here is actually that in tachycardia, the A in the lateral RA does seem to be earlier, right, than the A in the His. Also, during AVNRT, right, what is the normal, we always talk about how you can use the R to P interval, which is, of course, the ECG surrogate of the ventriculoatrial time, or VA time. What do we say is the sort of line in the sand that will distinguish AVNRT from ORT? How many milliseconds? If it's more than X milliseconds, is it's ORT?
70.
70, right. So generally speaking, we would say that if the VA interval exceeds 70 milliseconds, then it's more likely to be ORT. And that's because it simply takes more milliseconds to go down the His-Purkinje system to the ventricle, come back up to the pathway. This process takes at least 70 milliseconds, although my buddy Scott Seresnak wrote a paper a couple of years ago showing that in small kids it could be like 50, or he made the argument that maybe we should use 50 or 60. But in AVNRT, the VA interval can be 0. It can even be negative because it may take less time to go from the AV node to the A than it does to go from the AV node through the His to the V. So sometimes in AVNRT, the actual quote unquote retrograde A precedes the onset of the V and is negative. In this case, if we look in the His, you don't have calipers, nor do I, but it's very clear that there's a big separation between the ventricular electrogram and the atrial electrogram. And I can guarantee you that this is significantly more than a 70 millisecond interval. The mere fact that you can so clearly see an A separated from the V in the His is suggestive of the fact that it is not AVNRT, in which case it would usually be buried in the QRS or in the ventricular electrogram in the His. And the fact that the lateral RA is a fair bit earlier than the His A is very suggestive of it being a pathway. So in this case, we would say that based on this tracing, what goes with it being a pathway is the fact that the lateral RA is actually earlier than the His A, but also that a His refractory PVC advanced the following A. So those 2 points, that the A was advanced with the His refractory PVC, and the fact that the lateral right atrial electrogram preceded the His A, both of those would be very strongly supportive of a pathway. And I would agree with Ivana that the fact that this is such a slow tachycardia would suggest that if we may not call it PJRT, but there is clearly something very slow about the conduction. I think in this case, though, interestingly, so in PJRT, why is it, Ivana, that people have slow heart rates in PJRT? What is slow about the tachycardia in PJRT? What part of the limb of tachycardia is very slow?
Going up the accessory pathway is what is.
Yes. Right. So accessory pathways in PJRT tend to conduct very slowly. What's interesting here is that although there is some interval between the V and the A, it's not very long. But what is long is the A to H interval, right? If this is 460, then this means the AH is probably like, I'll make up a number, but it's probably like 300, which is pretty long for somebody at a heart rate of 130. So in actuality, this could be an example of ORT and somebody whose AV node ain't so great. Now, why would that be? So one of the most common reasons we sometimes see this type of pattern, and it's not PJRT, is because when we place the His catheter, we inadvertently bang it and cause some transient AV nodal slowing. This is one of the really big frustrations for electrophysiologists, is that sometimes just by placing your diagnostic catheters, if you just happen to push a little too hard in one area, you can get transient AV block or transient AV slowing or prolongation. And then you're really in deep crap because you can't actually induce SVT, or the SVT is, you can only get single beats of it, and makes the case very difficult. And particularly earlier in my career, when I was a little bit more brutish, I would on rare occasion have cases where we would put up the catheters and we couldn't induce anything. And the first AH interval was 175 milliseconds. And we're like, oh God. So what we would typically do in that case is pull the His catheter out and just sort of sit there for a while and watch the PR interval normalize. But sometimes there were rare times where the injury was significant enough, the bruising of whatever happened in the heart was significantly enough that it actually resulted in our inability to induce tachycardia and inability to actually proceed with an ablation. So in this case, I think that that might be what happened in this case, that during placement of catheters, maybe either that or there was just a pre-existent slow AV node. But it is curious that at cycle length 460, the AH is like 300, right? In any of us, if we pace the atrium at a rate of 130, your AH might be 100, 110, but I doubt seriously it would be 300. The only way it would be 300 is if somebody had dual AV node physiology and actually had AVNRT and ORT, but that's not the example that we're looking at here. So anyway, this business about a PVC during His refractoriness is very, very important. Now, there is one thing that you should know. So this will determine between ORT and AVNRT, but remember that if we are in atrial flutter, where all of the reentry is in the atrium, a His time PVC will also have no impact on the atrial activity. The atrium should continue to depolarize in this exact same manner. So a His time PVC will distinguish between ORT and AVNRT, but it does not tell us whether if there is no offset in the next P wave, it could still be AVN, it could still be ORT. So sometimes when I'm really not sure if it's possibly that, the next thing I might do is to give a dose of adenosine in tachycardia to see if it terminates tachycardia or if the tachycardia in the atrium continues. Clearly, if it were atrial flutter, we would not expect adenosine to terminate the arrhythmia. If it were AVNRT, it would terminate, at least transiently. So sometimes I do both this and give adenosine to be 100% certain of what we're dealing with. Okay, any questions about any of that? All right, I think we'll stop here. I hope you found that somewhat useful. I know we review some of these topics a number of times during the year, but I found when I was a fellow that because you don't do EP all the time, it's helpful to re-review some of these concepts over and over, and so that it's almost like banging it in a little bit. Do you mind that I review some things a few times over?
No, please continue to do so.
All righty then. I hope everybody has a wonderful day. I'll see you at sign out in just a little bit. Thank you. Bye, everyone.